ultrasound. And also thank you for the fellows for a lovely evening yesterday. It's an honor to get to know you more. You're all stars in your own self, so you have a great future coming ahead of you. So Joanne asked me to talk about first trimester ultrasound. It's an area that's gaining a lot of attention. So I figured I'd give you my take on where we are today. I'll focus on primarily one plane, the mid-sagittal plane, which I think has a lot of power to be a screening tool for first trimester ultrasound, and I'll share with you our protocol that we currently follow at our institution. So my prediction is that the first trimester ultrasound would play a major role in clinical management of pregnancy in the next 3 to 5 years. I think we're behind Europe on this. There's a lot of data nowadays that suggests that the first trimester ultrasound can fill a significant role for not only pregnancy screening, but also for fetal malformations in the first trimester. So what do we do today with the first trimester ultrasound? We certainly date pregnancy accurately. We diagnose multiples very well early on. It's an important part of the first trimester ultrasound to diagnose multiples and also assign chorionicity early on. And we do some risk assessment with nuchal translucency, and in Europe we do preeclampsia assessment in the first trimester and risk for severe IUGR, and we evaluate the adnexal. So that's currently what the first trimester is. And I'll just expand a little bit on those specifics. So as you know, the first trimester ultrasound should date a pregnancy if the patient presents with no menstrual dates. And the first trimester is the most accurate time to date a pregnancy. And the crown rump length is the single most important biometric measurement for pregnancy dating. And the criteria for the crown rump length, as defined by the task force on residency education, is make sure the focal zone is at the appropriate length. The image is magnified where the fetus occupies at least about half the image. The embryo and the fetus is imaged in a neutral position with some amniotic fluid seen between the lower chin and the chest. You measure the maximum length of the embryo or the fetus shown, and the maximum length should be from the straight line from the cranial portion to the caudal portion of the embryo or the fetus. So the word crown rump is a misnomer because this is actually the crown of the fetus, but the measurement should be the longest distance that you can achieve from top of the head to the bottom. And you know from the ACOG guidelines that then you should obtain a mean of 3 discrete crown rump length measurements and use more than 5 days to assign date by ultrasound if there's a more than 5 day discrepancy at less than 9 weeks, and more than 7 days greater than 9 weeks, between 9 and 13 weeks. We use the various biometries, the VPT head circumference, the down circumference, and femur length between 13 and 14 weeks in the first trimester. You know about the importance of the first trimester ultrasound in diagnosing multiples, but also in assigning chorionicity. About 100% ability to do that in the first trimester. That drops to 90% in the second and third trimester due to crowding. And also primarily the risk assessment that we do today in the US is looking at nuchal translucency and providing risk assessment for aneuploidy, for pregnancies, also the nasal bones, and there's a task force that has met recently to look at the data with regards to using risk assessment using urinary Dopplers in the first trimester along with other biologic markers, and providing some risk for the pregnancy with regards to the early onset IUGR or early onset preeclampsia. And I think we would have some guidance coming up from this task force in the next 3 to 4 months. We also look at the adnexa, primarily looking at some of the common adnexal masses that you could see in pregnancy that are listed here, but certainly for suspicious masses such as borderline tumors or malignant tumors in pregnancy. There's an evolving role of the first trimester ultrasound, however. That is related to imaging in the obese pregnant women. As you know, imaging in the second trimester could be difficult in the obese pregnant women because of the distance to the uterus, but also because of the position of the fetus and the tissue density that exists in some of the obese women. And also, how would we screen for fetal malformations in those pregnancies? There's a lot of data, some that has been done from NYU here, from Dr. Elon's team, and some that we've done here that shows that when you get to a BMI greater than 40, as you see here, the first trimester ultrasound becomes a more important ultrasound to complete an anatomy survey, and this is looking at a detailed ultrasound exam, the 76811, than the traditional second trimester ultrasound. And if you combine the first and the second trimester at 18 weeks, first trimester ultrasound and the second 18 weeks, you're able to complete the anatomy much better than the traditional approach, which is doing the second trimester ultrasound and then repeating it in 3 to 4 weeks if you cannot complete the anatomy at that time. There's another important aspect in screening for fetal malformations that is resulted from the dissemination of NIPT as a screening tool for aneuploidy in our population. So when we are getting abnormal NIPT results in the first trimester, it becomes really important for us to do an ultrasound at that time to assess the pregnancy. Rather than telling the pregnant woman, well, you have a negative NIPT, we're going to do an ultrasound at 18 weeks or 15, 16 weeks. That's a long gap between getting the results at 11, 12 weeks and providing information that are very useful to that pregnancy. So putting all this together, it becomes really important to refocus the first trimester ultrasound and see what could we see today and what's the power of that. So the International Society of Ultrasound and OBGYN, they have guidelines on the first trimester ultrasound that has been published. It's open access on the website, isugog.org. There's currently an AIUM task force that is defining the first trimester ultrasound in the United States. And we're hoping to get information also that will guide us on what would be part of the first trimester ultrasound as we change from just dating a pregnancy to doing more detailed anatomy in the first trimester. There's a list of abnormalities that you should always detect in the first trimester. And here's, this list is displayed on the screen. Certainly early hydrops, anencephaly, alobar holoprosencephaly, body stalk anomaly, ectopia cordis, large abdominal wall defects, megacystis, and molar pregnancy placentas should always be visible and detected in the first trimester ultrasound. When you look at large studies, this is a study from Dr. Singilaki in Europe, more than 44,000 pregnancies about what could be diagnosed between 11 and 13 weeks. You can see in this series, acrania was diagnosed in 100% of the time, alobar holoprosencephaly 100% of the time, but look, diaphragmatic hernia in the first trimester in 50% of the time. So that's really important information. Looking at abdominal wall defects, 100% of the time with enlarged bladder. Going to 50% of lethal skeletal dysplasias, abnormalities in long bones, absent hand or feet, which is really important because that is not as evident in the second trimester as it is in the first trimester. And then you see some other major abnormalities here in 100% of the time. If you look at the data in the literature, the meta-analysis in low-risk pregnancies, 97,000 low-risk pregnancies, detection rate of fetal malformations in the first trimester around 32%, and in the high-risk pregnancies around 61%. So pregnancies coming to you either because of abnormal luteal translucency or an increased risk for aneuploidy or increased risk for malformation, about 61%. This is not that far from what we do today in the second trimester. So there's good information out there from several sources that really points to the fact that the first trimester ultrasound in today's technology can provide way more information than we used before. Now from this meta-analysis, the factors that impact the detection rate, the most important factor is having an anatomical protocol during your first trimester anatomy screen. And I think that's really an important part, is that if you decide you want to do this, I think it's really important as part of your training, of your staff, to have a protocol that everybody follows in the clinic that goes through what you expect to see as part of your evaluation of the fetus. And I will share with you towards the end of this presentation what we use at my institution. Now, when should you do the first trimester ultrasound? Certainly there's a trade-off between doing the ultrasound early and providing information early to the patient and detection rate of malformations. And you can see at 11, 12, 13, 14 weeks, there's an uptake in detection rate, but it tends to level off as we move into 13, 14 weeks. It appears that there's a sweet spot somewhere around 13 weeks that provides you a fairly high detection rate and at the same time early enough in pregnancy that patients have choices, or if you want to do detailed genetic testing and that you need lead time, you can do that and have enough time to get the information to be useful for the patient. So what I will focus for the remainder of this presentation on the mid-sagittal plane of the fetus. So you may ask, why the mid-sagittal plane? I think there's a lot of important features of this, but first, this is a plane, it's the same plane as the nuchal translucency plane. So there's a lot of advantage for this because we have developed standardized criteria for the nuchal translucency plane. And for the past 10 years, we have actually established a mechanism for certification of sonographers and physicians. And now there are a large number of physicians or sonographers that are already certified in the nuchal translucency measurement. And this is the only ultrasound plane in obstetrics today that we have established criteria and developed a certification process that have been widely adopted in the United States and across the world. And if you look at the program, the NT2R program, which is the nuchal translucency program, and the Fetal Medicine Foundation will show you the same thing, that if you follow the cohort of physicians and sonographers over time, their performance in doing the nuchal translucency gets better over time with the feedback that is provided to them from the process of certification. So not only we've developed certification for a plane, we've trained physician sonographers, but we provided feedback to improve performance over time. Also, the nuchal translucency plane, as you know, happens to be associated, the wider the nuchal translucency, the higher is the association with major malformation. So it makes sense to rely on that plane as a screening tool for the presence of abnormalities. So what should you look for in the nuchal translucency, in the nuchal translucency or the mid-sagittal plane as a screening in the first trimester for fetal malformations? So we talked about nuchal translucency, so that should be part of what you look for when you obtain that plane. Second, you look at the nasal bone. Third, you look at the midbrain and the anatomy of the midbrain, and I'm going to go through these in detail. You look at the maxilla, you look at the mandible, you look at the cord insertion in the abdomen, and you look at the bladder. And once you've done this anatomy survey, and once you get used to this, it takes you 10 seconds to be able to screen for all these anatomic parts of the mid-sagittal plane. And then once you're done with this, we recommend that you get a color Doppler view to look at the angle of the ductus venosus, the umbilical vein, and that's the ductus venosus, and which direction it's angling. And also we recommend that you get a 3D plane looking at the extremities, looking at the hands and feet of that mid-sagittal plane. So let me take you through the details of what you should look for as you do this. I don't want to spend much time on the nuchal translucency. You know the value of it both for aneuploidy screening as a screen for cardiac malformations and for abnormalities. As you know, there's an association between aneuploidy and the widened nuchal translucency. And I think the NT was the reason why the first trimester has gotten the attention it did, because patients were referred for enlarged NT. We needed to look at the anatomy to see if there are any associated abnormalities. With regards to the nasal bone, just want to highlight and to the fellows and residents in the room that an abnormal nasal bone is not only a nasal bone that is absent, but a shortened or hypoplastic nasal bone is also abnormal. So keep that in mind. And if you look at how important is the nasal bone in aneuploidy screening or in aneuploidy association, you look at an absent nasal bone is present in about 2.5% of patients of normal fetuses in the first trimester. Absent in 60% of trisomy 21, 53% of 18, and 45% of 13. So it's a common feature in the most common trisomies that we look for. And if you look at this slide, there are 6 fetuses with trisomy 21. Some have absent nasal bone that you see here. Some have shortened nasal bone, and some have hypoplastic nasal bone. So as you look at the nasal bone, keep that in mind that its absence is significantly important, but if it's shortened or hypoplastic, it has some significance with regards to the abnormality. Next, let's look at the maxilla. The maxilla is this bone that you see. There are 2 maxilla, one on each side, and in the mid-sagittal plane, you will see one of them that is highlighted here. There are actually two bones. If you look very closely here, there are two bones that are on top of each other. Here's a schematic of the maxilla. There's the vomer bone, which is the bone on top, and then there's the maxilla under. And we're going to use this whole segment as the maxilla and the discussion. Why is it important to look at? Here's a normal fetus here and here, looking at the maxilla with some fluid in the pharynx, and the relationship of the maxilla here to the mandible. In looking at the maxilla, you need to look at any defects that exist in the maxilla, what's termed as maxillary gap. Maxillary gap is a marker for cleft lip and palate in the fetus. It's present in about 96% of non-isolated cleft lip and palate and 65% of isolated cleft lip and palate. Remember that in the first trimester, normal fetuses have a maxillary gap in about 5 to 7% due to the kind of not full ossification of the bone. When you have bilateral cleft lip and palate, you should see also a maxillary protrusion. So when you look at the maxillary gap, you look at a defect that could be present either in the middle of the maxilla, in the proximal portion of the maxilla, or in the distal portion of the maxilla, as you see here. Here's some examples. Here's a big portion of the maxilla that is absent anteriorly in a fetus with cleft lip and palate. Here's a proximal portion of the maxilla that has a large defect in it, as you see here, in another fetus with cleft lip and palate in the first trimester. And here's a shortened maxilla with gaps on both sides in a fetus with bilateral cleft lip and palate, and you see this protrusion that is apparent in this mid-sagittal plane. Now, when you suspect a maxillary gap, you need to do other planes in the fetus to confirm the presence of a cleft lip and palate. So we talked about the sagittal plane or the mid-sagittal plane, but then you go to an axial plane, looking at the alveolar ridge, and then the coronal plane at the retronasal triangle to look at the alveolar ridge and the maxilla on each side. So these are, once we suspect there's a gap, then we go to the other extreme, and certainly the 3D ultrasound is quite helpful early on to confirm the presence or absence of a cleft lip and palate bone. Next, let's look at the mandible, so in this mid-sagittal plane. So here's the mandible right here. There are two mandibles, and again, you see one of them in the mid-sagittal plane. The importance of the mandible is in the assessing for the presence of micrognathia in the fetus. So on 3D ultrasound, if it's severe, this could be very prominent, as you see here. But looking at a normal mandible, when you draw a line from the anterior edge of the nasal bone to the anterior edge of the maxilla, the mandible is on the outer side of that line. If the mandible is on the inside of that line, then you think about micrognathia. And why this is important in the first trimester, not only because of the association with syndromes such as Pierre-Robin or others, but because in our experience and that of others, that micrognathia is much more pronounced in the first trimester than it is later on if you follow that pregnancy perspective. Here's a fetus with Pierre-Robin syndrome. You could see the first trimester at 12 weeks how impressive that micrognathia, but as you follow in pregnancy, that becomes less impressive and less